Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Therapeutics. If you don't know, my name is Rain Bennett. I am your host, and I am grateful to be here every week. I'm a filmmaker and live video host, virtual TV show host as well. I've been working with CCF for almost a decade to create video content, whether it's live video series like this or produced video series where we're talking about treatments, or we talk about how patients psychologically deal with this and navigate this disease, all with the same mission in the back of our minds, which is to raise awareness and educate people about neuroendocrine tumors. That is what we are trying to accomplish, and I feel like we're doing pretty good. And with this show specifically, I see it as a two-sided mission. Continue to do that mission, which is to spread information and education and awareness about this disease, but also provide community. And that's one of the things I love so much about everybody who comes back to the show every week. You know, the benefit that I see from the community is almost just as powerful as the information. You all sharing your stories with each other, and I think that's super, super helpful. So if you're just signing on and don't know the drill, let us know where you are in the world. We'd love to see how far these programs reach. And if you do know the drill, if you're a friend of the foundation, you've probably already started doing that. Hello from South Africa. See? Even live, this Australia as well. I know it's probably late there. Even live, we get so many attendees from all over the world, and that is outstanding. Listen, I have an extra thing to ask this week. Let us know where you're from. And then also, as I just kind of alluded to, we have a lot of people who are here every week, and we appreciate you so much. Let me know, I'm just curious in the comments, how many of these, maybe not how many you've attended, unless it's just like one or two, but how often? Are you here every week? Are you here 3 out of the 4 weeks of Thursdays out of the month? Let me know about, we'd love to see how many people are here every week, because I suspect that it's a good number just because I see the same faces or the same names at least. And I think that's really a big part of the value that we provide. So let us know. Of course, we always want to thank Therapeutics for their support of Luncheon with the Experts. We would not be able to do this program without them. And we always like to include this disclaimer from them. And that is the opinions expressed by the guest presenters, as well as the questions asked by you all, the audience at home, haven't been created or suggested by the sponsors of Luncheon with the Experts. And CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation. Audience members should not rely solely on the opinions or information expressed by the guest, and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatment. So that last line is definitely the takeaway there. We're going to give you some good advice, hopefully answer some of your questions, but we don't know your specific case. So what I want you to do is take that advice and that information, bring it back to your home team who does know your specific case, and then make the best plan to go forward from there. All right, today our guest is Dr. Daneng Li, who goes by Dan. Dr. Dan Li, how are you?
Great. How are you doing, Ray?
I'm pretty good, man. Thanks so much for joining us. I appreciate it. Excited to hear from you. I know that people are excited to hear from you. Before we get started and dive deep into today's episode, let the folks at home who maybe don't know who you are or where you work or what you do, let them know a little bit about yourself, how long you've been working with this disease. And the way I like to put it, sure, you have a title. We'd like to know that too, but what is your role as you see it in the neuroendocrine tumor community?
Sure, absolutely. So I'm Dan Li. I currently co-direct both the liver cancer as well as the Neuroendocrine Tumor Program here at City of Hope. I did all my training actually on the East Coast in New York City. So did my medical school at Cornell and then stayed on for residency at a New York Presbyterian. So one of my med school classmates was actually, Dr. Halprin, who you've had on the show before. Absolutely. And everything. So it's kind of a small world, how things work out. I ultimately stayed on to do my oncology fellowship at Memorial Sloan Kettering. So trained with very good people like Eileen O'Reilly, as well as, Dr. Diane Reedy, who's, an expert in this field. And then after finishing fellowship, there was an opportunity here at City of Hope to build the program specifically in both liver cancer as well as neuroendocrine cancers. So this was a good opportunity for me to kind of build my own program. So I came out here and was able to really kind of grow the program in the last 5 years. I think, my experience with neuroendocrine tumors is that initially when I was in fellowship, I saw predominantly pancreatic neuroendocrine tumors because my focus was initially in pancreas. But I was able to make the transition because I just had such a diverse experience in GI oncology. And I see a lot of similarities in terms of the various types of treatments that we use, for example, in liver cancer, that I think have very good opportunities for neuroendocrine tumors. And I think if you find a doctor that has the ability to kind of translate between diseases, oftentimes that's an advantage because they already know certain therapeutics that are developed in other diseases that potentially will have an effect for neuroendocrine tumors. So here at City of Hope, we've been able to really focus on kind of a multidisciplinary approach to neuroendocrine tumors. So really involved with our expert surgeons like Dr. Gangadeep Singh, as well as Dr. Yuma Song, who are world-renowned surgeons here. So doing a lot of research in terms of surgical approaches for neuroendocrine tumors, as well as various numerous types of innovative clinical trials. And for me personally, I also have a interest in outcomes research, so very involved with patient advocacy groups such as LACNets. We've been able to develop a tool in terms of Net Vitals, which we hope is really helping patients on their journey with neuroendocrine tumors.
Got it. How many, what's the percentage of your patients that are NET patients?
So the only patients I see right now are just liver and neuroendocrine. So I would say, over 50% of my patients I see are neuroendocrine tumor patients. Yeah.
Got it. Copy that. Okay, folks. So now you know a little bit about our guest, and you can start sending your questions in. We'll try to get to all your questions. As I always like to ask, we can't get too specific with your case. Dr. Li, obviously, if he doesn't work with you, doesn't know your case, and we just don't have the time to dive into it. And there's so many unique qualities about each case. So I would ask you to present your question in kind of a general way that gives you the next step of your answer, the information you're looking for. And then I encourage you to follow up with CCF afterwards. If you have other questions, or if you didn't get your question answered, you can reach out to them here on the Facebook page. You can send them a private message. You can also reach them at their website, carcinoid.org. But try to phrase your questions in that manner. And then I have my two asks that I ask at the top of each program. One of the main benefits, if not the biggest benefit of this show, is this interactive virtual one-on-one session with an expert. That's the point. That's why we're providing it for you. So the most value you can get from this is to ask your question here and take advantage of that interactive nature or quality of the show. So if you know someone that would benefit from that and may have a question or want to learn in this environment, you can tag their name in the comments now, or you can share this video to their page and let them know it's going on live. That'd be the best way to get them here and get them that value. However, if they don't make it, or if you want to revisit the video, it will be evergreen. It'll live on the videos tab here on the Facebook page of CCF. And starting Monday, we republish it to YouTube for those who don't have Facebook. But if you can get people here now, that would be the most benefit for them, as well as us. We want to have as many people here as possible. And then secondly, and you all do a great job of this and really helps me do my job better, if you see a question in the comments that you also have or you would like to know the answer to, you can like it or love it, or any of the reactions that Facebook gives you access to. Any or all of those, let me know that there's a demand for that question. As I'm looking at the questions, if I see that 6 people have liked that question, that tells me that there's a high demand for it, and I'll make sure to get it across, because inevitably we get so many questions that we can never get to them all. And I see that as a good problem. It allows us to continue doing our job, but I wish that we could. But that's a way for me to get to those questions that would reach, and impact the most amount of people. And that's what I'm trying to do. And finally, before we get started, I always like to ask if you have downloaded CCF's Net Cancer Health Storylines app. This app is awesome, and it makes it very, very easy to record your symptoms, your nutritional concerns, your medications, your moods, all of that. So if you haven't, check that out. We will put a link in the comments bar. And to that point, if there's anything Dr. Li refers to today, a resource, a medication, an article, anything like that, we will try our best to get that link in the comments as well, so you don't have to pivot away and start Googling or write something down furiously. We'll try to get you that information. Our job is to make it as easy as possible for you folks. So let's see what we got here. I see a lot of people who are, you're their doctor, so they're all excited to see you. Here's a question right off the bat from Polly, and Polly says, what blood work do you need if you have carcinoid tumors? I'm not sure I understand that question, but do you?
Sure. So I think that's a great question, Polly. So, you know, if you're newly diagnosed with neuroendocrine tumor, one of the things that we talk about for the newly diagnosed patient is what type of neuroendocrine tumor they have. As you know, many have come to realize this is really a heterogeneous group of different types of tumors. So the first thing that we need to know is potentially where the primary location of the tumor is. And then once we determine that, one of the things that we need to understand is whether or not it's a functional or non-functional neuroendocrine tumor. And what I mean by that is a functional neuroendocrine tumor is a neuroendocrine tumor that particularly releases certain types of hormones or peptides. And this is relevant to your question because for those patients that have functional neuroendocrine tumors, there are specific type of blood tests that we would do. So the most common type of hormone that's released from the old term of carcinoid tumors, which are just well-differentiated neuroendocrine tumors outside the pancreas, is serotonin. So you can measure serotonin in different ways. You can measure it with just a general serum serotonin, which is fairly inaccurate. You can measure it as a 24-hour urine 5-HIA, which is more accurate. And then these days, various different types of institutions might have a blood test that calculates the serum 5-HIA levels, which is, you know, very good to measure the excess amount of serotonin that's potentially produced by your carcinoid tumor. Outside of that, I think there's a lot of debate in terms of which blood test to do. Some of us might do a serum chromogram A, which is a non-specific blood biomarker of the tumor bulk. It's not entirely accurate in all patients. One of the main reasons why that is there are a lot of other things that can potentially cause the chromogram A to increase, such as proton pump inhibitors, which are a common class of medications that we might use for reflux disease. So there's a lot of debate in terms of whether or not chromogram A is a good test, and then there are additional other new tests that are coming that have been discussed previously, but they have not been yet validated, so I wouldn't go into that today.
Got it. Let me ask you, you know, with this disease, with each case of this disease being so unique, what's your, I mean, this is a big question and I'm aware of that, like, what's your approach? I mean, in other diseases, you really look at patterns, you know, that you've seen before. How do you approach this disease when each case it can be so vastly different?
I think that's an amazing question, Ray. And I think that this is the area where, you know, I like to confront it really on an individual basis. And I think we really try to push the envelope here at City of Hope because, as you said, this disease is so heterogeneous, right, and everyone's case is so individualized that what I believe is that it has to be an individualized approach. So one of the struggles I think that patients have voiced to me is, you know, how could you have a diagnosis where you potentially go to 10 experts in the field and you can potentially get 10 very different opinions? And the reason why is because, just as you've highlighted, it's so individualized. And I think it's so important for patients to find a physician that they're comfortable with in terms of their train of thought, how they approach the disease, and is in align with the patient's preferences as well, because that goes a far way in terms of earning that trust between the physician and patient relationship. And that's so key. And that's absolutely crucial because we have such limited data in the literature in terms of how to approach neuroendocrine tumors once we get past a certain stage in the treatment journey, such as initial therapy. And our guidelines are all, you know, very loose in terms of consider this approach, consider this approach, consider this approach. And the reason why that is because no one has been able to show just one way that is superior to all the other ways in terms of treating a specific diagnosis. So what I encourage people to do is to get those, multiple opinions, make sure that you are aligned potentially with the physician that's treating you, because that's so important from a trust perspective, and be open to potentially going outside of sometimes guidelines, because your case might be individualized and might require that for the best outcomes.
Got it. Thank you for that. Real quick before we get back to questions, Lisa from LACNet says, woohoo, thanks for the shout out to LACNets. We are proud to have co-developed Net Vitals with you. And thanks for presenting to NANETS last fall. So I have a question from Rebecca. Rebecca says, when I get my treatment every 28 days, Sandostatin LAR injection, Zometa infusion, and B12 injection, sometimes it makes me so fatigued I hurt all over with joint and muscle pain. This we've been hearing a lot lately. And it can last up to 4 days. Should I be getting fluids with the infusion, and will an MRI show nets in the liver?
So I think that's a great question. I think there's a couple of different questions in that question.
There were a couple more too.
I'll try to, sure. I'll try to tackle this one at a time. I think the biggest question is, side effects of Sandostatin in terms of joint aches, fatigue. We certainly know that Sandostatin can potentially cause these symptoms. But at the same time, just having a diagnosis of neuroendocrine tumor can sometimes cause these symptoms as well.
Okay.
So one of the first things to distinguish is whether or not you had those symptoms even before you started treatment with Sandostatin. And if you didn't, then potentially it's more attributable to the injection itself. And here, I think there's a couple of different ways to do it. I think potentially before doing fluids, sometimes if a patient does not tolerate one somatostatin analog therapy, we will oftentimes switch to the other somatostatin analog therapy. So if someone doesn't tolerate, let's say, Sandostatin, we will switch to lanreotide. If someone doesn't tolerate lanreotide, we will switch, to Sandostatin. And we've had good experiences because for whatever reason, a patient might not tolerate one over the other. And sometimes that can resolve a lot of the side effect issues. Fluid hydration sometimes can help support you with the fatigue. That traditionally has been more done when we have, let's say, used, for example, chemotherapy for, poorly differentiated high-grade neuroendocrine carcinomas to kind of get them through the initial fatigue and dehydration from the chemo. It's less used to kind of support injections, but I would say if everything else fails, and obviously I don't know the specifics of this case, but if you're having some, diarrhea or feeling dehydrated, not taking in good oral fluid intake, then certainly supportive hydration, let's say once a week or twice a week during that time, can be done and can help as well. And I think the other question, Ryan, can you remind me what the other question was? Sure.
For sure. Should I be getting fluids with the infusion? And then
so we talked about that.
Yeah. And then will an MRI show nets in the liver?
Sure. The question regarding MRI showing nets in the liver is a very good question. This is a question that I often hear a lot from our patients in terms of what is the optimal imaging that I should be doing as I follow my diagnosis of neuroendocrine tumor, or when I'm trying to diagnose neuroendocrine tumors. I would say for patients that have neuroendocrine tumors that have traveled to the liver and have spread to the liver, the MRI imaging is much better quality compared to traditional CT to identify the disease in the liver. So for a lot of our patients that have liver predominant neuroendocrine tumors, we will oftentimes follow our patients with an MRI of the abdomen with EOVIS contrast to better evaluate the liver lesions, as well as a CT of the chest if they have disease in the lungs as well. And for our patients that don't have necessarily significant disease in the liver, then we will still follow with traditional CT imaging.
All right, thanks, folks. If you are just joining us or joined us a little bit late, this is Luncheon with the Experts, and we are here with Dr. Dan Li from City of Hope. Speaking of City of Hope, we had a question. Dr. Li, where did it go? Wanted to see if you were planning on seeing patients. There it is. Starting seeing patients at the City of Hope Irvine campus in 2022.
Yeah, so that's also a good question. As our institution have continued to expand out, one of the initiatives is that we've been building a second campus in Orange County, specifically in Irvine. And that's going to be really an extension of our main campus here in Duarte, and really have hopefully similar extension of options such as innovative clinical trials as well as good surgeons. We haven't made a decision whether or not our physicians will travel between the two sites. I think the initial idea is really to have physicians that are based in Orange County that can potentially collaborate with our physicians in Duarte. So for me personally, at this time, I don't plan on going down there right now, but there could be changes in the future if we feel that there's a need to further expand out.
Yeah, that'd be a little bit of a trek, right? What's the distance there?
Yeah, so some of our physicians have done it as part of a pilot program. Some of our physicians have lived closer down there. So what they have done is that maybe for 2 days of clinic, they do it here on Duarte main campus, and then they have another clinic 1 day in Irvine. So that is a model that's been instilled in multiple other institutions across the United States, and that's potentially something that we will explore as well, depending on what we see are the needs are and how our clinical trial portfolio evolves moving forward.
Got it. Well, thank you for your question. Next question from Deborah and a few other people as well. What substances does the chromogranin A test for?
So that's a good question, Deborah. So again, it doesn't necessarily test for a specific substance per se. This is essentially the chromogranin A is a result of a peptide that is normally produced in the body. And like I said, there's a lot of different non-specific things that can lead to a rise in it. And as a result of that, it's not as good of a biomarker sometimes as what we would want. But for some patients, it does potentially correlate with tumor bulk. So tumor bulk from the neuroendocrine tumor is one of the things that can correlate with chromogranin A levels, and that's why we really follow this.
Got it. Follow-up question. How can you have high chromogranin A with normal serotonin? That's also from Deborah, so I'm assuming that might be her situation. How can a patient have high CGA and normal serotonin?
Sure, Deborah. I think that's a great question, and that's oftentimes a confusion. And I think, maybe it's us as physicians not doing as good of a job explaining to patients. I'm very in tune in terms of physician-patient communication. So again, to just take a step back in terms of how we think about neuroendocrine tumors, one of the things that we make a decision on for our patients initially is whether or not someone has a functional or non-functional neuroendocrine tumor. And for the patients that have functional neuroendocrine tumors, those are the patients that will potentially have excess serotonin production. Whereas the non-functional patients, they will not have excess serotonin production, so their serotonin levels might not be elevated. Chromogranin A is completely separate from that. So patients that have non-functional neuroendocrine tumors, as well as functional neuroendocrine tumors, can have elevated chromogranin A levels, because chromogranin A is just a reflection of how much potential tumor bulk you have in terms of what is the overall volume of the disease, rather than the serotonin, which is a measure of how much excess hormone that a functional neuroendocrine tumor is specifically producing.
Got it. Thanks, Deborah. Our next question from Myra. Do you recommend Effient for retroperitoneal lesions?
That's also a very good question, Myra. So I don't understand. I don't know your specific situation. I will just cover this question in terms of broadly in terms of how I feel about Effient as a treatment option for our patients with neuroendocrine tumors. So Effient is a medication or an mTOR inhibitor that we use for neuroendocrine tumors, whether it's pancreatic neuroendocrine tumors as well as well-differentiated neuroendocrine tumors outside of the pancreas, whether it's lung neuroendocrine tumors or GI neuroendocrine tumors. In general, I would say usually if you have, let's say, a diagnosis of a well-differentiated, low-grade, small intestine neuroendocrine tumor, and initially you're on somatostatin analog therapy, and your disease develops resistance to somatostatin analog therapy. Oftentimes in this scenario, we will favor, let's say, a treatment such as Lutathera PRRT over Effient, just because we know that before from a study known as the RADIANT-2 trial that encompassed a lot of patients with functional neuroendocrine tumors, which were predominantly small intestine neuroendocrine tumors, that Effient, while there was a trend in terms of improvement in disease control with the medication, it did not necessarily technically meet statistical significance. So in that scenario, we tend to use Effient, let's say, later on after Lutathera. Now, for patients that have neuroendocrine tumors, let's say, of the pancreas or neuroendocrine tumors of the stomach or rectum or lung neuroendocrine tumors, then it's a decision of when to use Effient that's based off of kind of how aggressive is the tumor growing, where are the sites where the tumor are growing. If it's growing relatively rapid and you need to achieve significant shrinkage, you might want to use another agent. But if you have relatively low volume disease and your disease is actually growing relatively slowly, then we can potentially actually consider Effient at that time. The advantages of Effient is that it's an oral medication. It's very portable. You take it every single day, so you're not coming in for any type of infusions or anything like that. And the advantage of a lot of these oral medications is that if you do have side effects, you can pretty much just stop the medication and immediately, within a few days, your side effects go away. So that's the advantages of oral medications compared to, let's say, more infusional medications that are much more long lasting during a period. So those are kind of the things that we think about. And as Ray mentioned, everyone is so individualized. And this is where we have to look at the individual case in terms of the overall volume of disease, how fast is the disease growing, what type of neuroendocrine tumor you have, and all of those things play such a pivotal role in terms of when we decide to use Effient over, let's say, another agent during your treatment for your neuroendocrine tumor. So specifically for your question for retroperitoneal disease, you can definitely use Effient for retroperitoneal disease, but the more, more complex question is kind of, should you use it at this time point compared to something else, depending on where you are in your journey.
All right. Thank you, Dr. Li, and thank you, Myra. Dr. Li, you had briefly mentioned in that answer, lung nets as you were listing off the different areas. Do you have a lot of experience with lung nets? Do you work with lung net patients?
I do,
Okay.
just because, when I came to the City of Hope, I really, there's two train of thoughts in the field for, in this field for approach to lung nets. Exactly. Some institutions will have a thoracic oncologist treating lung nets. Other institutions will have a neuroendocrine tumor specialist treating lung nets. Usually, if most of us are trained in GI medical oncology, and I think that's completely okay, just because oftentimes when I approach lung neuroendocrine tumors, I might start, let's say, a target therapy, something like Effient that we just mentioned, over very aggressive chemotherapy that sometimes a thoracic medical oncologist might initiate. So I think there's two different approaches, and we don't know what's the best approach, and I think that's definitely a a research area that still needs to evolve over time.
Yeah. Do you think that, I may be wrong on this, but do you think that historically it was approached from the thoracic perspective, if you will, and then is now transitioning to net experts handling it? Or is it really just like case by case, institution by institution?
I think it's a combination of both, but
Okay.
I think, as the field of neuroendocrine tumors has continued to grow, a lot of us who are experts in the field have, wanted to treat our lung neuroendocrine tumor patients, just because I think we've come to realize that there has been an approach. And this is certainly not the fault of my thoracic oncology colleagues,
Right.
because again, if you look at guidelines like NCCN guidelines, oftentimes for lung neuroendocrine tumors, the initial guideline is, especially for the atypical carcinoid tumors of the lung, the initial guideline is to potentially consider, platinum etoposide chemotherapy. And I think for us that are more trained in GI neuroendocrine tumors, we probably wouldn't do that. We know the disease is a little bit different compared to other lung cancers, and we're like, let's slow down a minute and everything. I think we have time to, potentially try other therapies before we have to go to chemo.
Got it. Yeah, I think I've seen a question or two come across about lung net, so just was curious if how much time you had spent in that, because I knew that it's kind of it's one of those areas where it's a little sticky. And by the way, folks, for lung nets and many of the other topics like this, we have deeper dive produced videos that we've done. We did a lung nets video with a very unique case, a patient with a very unique case, as well as hearing from Dr. Ramirez, who at that time was at the NOLA Nets program, and Pam Ryan, the nurse navigator. So we have a video about lung nets if you'd like to look a little further into that. We have a video on a lot of topics, PRRT, surgery, et cetera, et cetera. So I encourage you to check those out when you have the time. Next question from Tara and a few others. Well, first of all, is it common for nets to be found in the breast? And if so, then the second question is, what is the standard treatment of nets that have metastasized to the breast? Assuming, Tara is assuming surgery, and then what is the standard protocol after that? So first,
that's a great question, Tara. Mm-hmm. So a primary neuroendocrine tumor that initially develops in the breast is exceedingly rare. Really rare. Usually, oftentimes, I would say if you have that diagnosis where the primary, meaning that the tumor started in the breast, is being called that it's a neuroendocrine tumor starting in the breast, I would really advise you to potentially get a second opinion pathology review, because oftentimes we've had those cases where someone was said to have a primary neuroendocrine tumor of the breast, and we reviewed it here, and it was actually more what's known as a ductal carcinoma with neuroendocrine features or neuroendocrine differentiation. So sometimes these cells will differentiate from the breast cancer to look like neuroendocrine tumor cells and everything, but they're not actually neuroendocrine tumors and everything. So that's one key. Now, neuroendocrine tumors that, let's say, develop at another site and travel to the breast, while it is also rare, we have certainly seen that. And that's the much more common presentation compared to a primary neuroendocrine tumor in the breast. And in those situations where the disease has traveled to the breast, you would manage this as you would for the primary tumor site where it's coming from. So if it's small intestine neuroendocrine tumors, where oftentimes we are very aggressive with surgical debulking procedures, that is a multidisciplinary discussion in terms of, should we debulk sites of metastatic disease if we can get clearance? And this is a very controversial topic. And I think, again, if you go to several different experts, you're going to get several different opinions. But we tend to be fairly aggressive in terms of debulking, not only in terms of the primary site, but also sites of metastatic disease, because we have shown, at least in retrospective analysis, along with large kind of cancer registry studies, that there's a potential for survival advantage in those patients. Now, the caveat that we give is that yes, this is self-selection because the patients that we take to surgery are usually the most healthiest patients. They tend to do the best as well. But I would also counter that argument by saying that, well, that's actually in real life, right? In real life, when we meet a patient and we're trying to decide for surgery, we're assessing you in terms of whether or not you're the healthiest patient. And we're going to only take those patients that we think is going to get that survival benefit and everything. So I think that's where it kind of comes in terms of how we approach this. But it's a very good question. It's certainly something that we need to continue to study in terms of what to do. But that's how we would approach it.
Got it. Thanks, Sarah. So Wendy and a few other people I've seen, Wendy says, basically the question is, what advice would you give, or what direction would you offer for NET patients that are non-peptide receptor positive? Like where to go from there? Very challenging question, Wendy. So for those patients that are not, I assume what you're implying is a patient that doesn't have a tumor that expresses somatostatin receptors. So usually there are a couple of scenarios where this occurs. Sometimes for patients with lung neuroendocrine tumors, they will not express somatostatin receptors, particularly those patients, for example, that have, let's say, a little bit higher grade of disease, like atypical carcinoid tumors of the lung. They might not completely express somatostatin receptors, or only a few of their tumors express somatostatin receptors and others do not. And I would say in those cases, obviously the challenge is that then somatostatin analog therapy, as well as treatments that target somatostatin receptors, are not beneficial, and we just wouldn't use them. So then you have to just think about other agents that are more broader, that are not targeting somatostatin receptors, like, let's say, everolimus or other oral target agents, or even potentially chemotherapy agents for those cases. The other scenario where this occurs is in those patients that have really poorly differentiated high-grade neuroendocrine carcinomas. We know that this is kind of a continuum of the disease, that as the disease evolves and gets higher grade and de-differentiates to potentially a poorly differentiated neuroendocrine cancer, even for some of these patients that initially had a well-differentiated tumor, which is rare, but we're seeing this more and more frequently as our treatments have gotten better. Then those patients will start to lose that somatostatin receptor protein, and in those patients, again, we can't really use kind of somatostatin analogs or treatments like Lutathera that target somatostatin. So we have to think about other treatments to use. Got it. Thank you, Dr. Li. Thank you, Wendy, for your question. Jules says, are there any serotonin inhibitors, especially on liver tumors, that can be prescribed? So, Jules, I hope I get your question correct. I think what you're talking about in terms of serotonin inhibition in the liver is that it's a case in terms of a patient potentially that has a lot of excess serotonin production, or carcinoid syndrome. And what's the best way to potentially tackle that, especially in someone that has disease in the liver, which can produce a lot of serotonin and then kind of bypass the metabolism, so that causes kind of the symptoms of carcinoid syndrome. So I think there's three approaches here. One of the ways to best decrease serotonin production is to reduce the tumor bulk in the liver, and you can do this either with surgical resection, liver-directed therapy, such as embolization procedures to the liver, and oftentimes that can lead to an immediate improvement in decreasing the serotonin levels that are traveled in the bloodstream if you have disease in the liver. The other option is obviously initially with somatostatin analog therapy to essentially block
the release of serotonin from the tumor cell. And then the final option is with telocrostat ethyl or Zermelo, and that's a tryptophan hydroxylase inhibitor that decreases the production of serotonin within the inside of the neuroendocrine tumor cell. So sometimes if somatostatin analog therapy is not enough to suppress the release of serotonin, then you might need to add on a medication like telocrostat ethyl to decrease the serotonin production within the neuroendocrine tumor cell.
Got it. Yeah, I think that covered it for sure. Next question from Tom. Tom says, Dr. Li, in general, after having 3 full tumor resections, what factors do you consider, or would you consider, when deciding if another surgery to remove a new active tumor versus SSA? Thanks.
Sure, that's a great question, Tom. So I think, you know, surgery is definitely one of our biggest tools that we have in the toolbox to treat neuroendocrine tumors. And I think if you talk to our surgical colleagues, like, you know, Dr. Liu and others and everything, they will definitely propose surgery before any of the systemic treatments that we have. And we've had a lot of debates and side discussions about that. So I don't disagree with that. But I would say for your case, if you've had, you know, 3 surgeries, then I think, and each time it depends on how fast kind of the tumor comes back, then we need to really start thinking about whether or not it's time to transition to a systemic therapy strategy. Because what that means is that, let's say if the amount of time where the tumor is coming back, initially, let's say it took 2 years before the tumor came back, and then after the second surgery, it's 1.5 years, and now after the third surgery, it's a year, then we're kind of going along this kind of whack-a-mole situation when we're going after every single tumor that pops up. We're doing surgery and everything, and there's only a finite amount of time that you're going to get the maximal benefit from the surgery. So those are the times to potentially consider a switch to systemic treatment. Now, I would say if you only have, let's say, 1 lesion in the liver that has popped up, and everywhere else it's completely stable, or you have no evidence of disease, then those are scenarios where you might consider, if it's a peripheral lesion in the liver, to still do a surgery to kind of wedge out the lesion, or potentially do liver-directed treatment to kind of spot treat that lesion, because then that will give you more time before you have to start systemic therapy. So there are kind of those unique situations where there's just 1 or 2 spots where you can quickly, you know, spot treat and everything, and that allows you to kind of buy more time off of systemic treatment. But if there's, you know, multiple lesions and you've already had 3 surgeries, then potentially this is time to, you know, transition to systemic therapy.
Got it. Thanks, Tom. Hope you're doing well, my friend. So speaking, Dr. Li, of treatments and sequencing of treatments, this is another question that we get from time to time. PRRT is obviously a great tool in the toolbox, as you say, but sometimes it doesn't work as effectively on people. And so many times we get the question that we have here from Shin Yu. I think I might be saying that right. Let me know if I'm mispronouncing that, and apologies if so. What would be the next treatment after PRRT? So I guess the assumption is it didn't work or as effectively as we had hoped. What falls next in the sequence there? What potentially falls next?
Yeah, that's a great question, Shin Yu. So for patients, let's say if Lutathera PRRT is used in the second line, usually then what do you use as kind of your next line of therapy after that? So again, I think this really depends on where your neuroendocrine tumor comes from. If it's coming from, let's say, the small intestine tract, then you know, everolimus would be kind of the next treatment that we would go to as the treatment in that case, or clinical trials, which I think I can get to, you know, at the end of this discussion. If it's, let's say, a pancreatic neuroendocrine tumors, then you have a couple of different options. You have target therapies like everolimus. You also have a VEGF inhibitor known as sunitinib or Sutent, And you also have potentially, chemotherapy with something like capecitabine temozolomide. And the decision, again, in terms of which agent you would go to is very individualized. So if you're trying to really achieve more of a stability of disease, agents like everolimus as well as Sutent are very good at stabilizing the disease. Oftentimes, significant shrinkage or 30% shrinkage of the tumors or more with these agents are usually more so in the single digits from the clinical trials. So you might not want to do that and go to these agents immediately if you have very bulky disease or your disease is growing very quickly and you're very symptomatic and you need to get immediate shrinkage of the tumor. In those cases, potentially, oral chemotherapy like, capecitabine temozolomide, those are, really good agents to potentially quickly have the highest chance of quickly, shrinking the tumors. And in that scenario, that's how you decide between those agents. And then for lung neuroendocrine tumors, it's very similar. You can potentially go to everolimus again as a FDA-approved treatment for lung neuroendocrine tumors. But then you can also go to various different types of chemotherapies, especially for potentially a higher grade disease, including IV chemotherapies like platinum etoposide chemo.
Awesome. Thank you for that thorough response, and thanks for your question. Okay, folks, we got about 15 minutes left. We're here. This is Luncheon with the Experts. We're here with Dr. Daneng Li. Hope you've been getting some great value out of today's program. Just to reiterate, if you have follow-up questions or we aren't able to get to your question, we always have a lot of them, reach out to Carcinoid Cancer Foundation either here on their Facebook page or you can message them or email them at their website, carcinoid.org. And you can always refer back to this video or anybody else that you want to see it. You can watch it again. It'll live here, evergreen, on the videos tab of the Facebook page of Carcinoid Cancer Foundation, along with the other videos that I've been talking about that we've been producing for almost 10 years or over 10 years. CCF has been putting out video content. So check that out. And then for those people that patients, caregivers, support group leaders, anybody else that would benefit that aren't on Facebook, we will publish on YouTube, CCF's YouTube channel starting Monday. So 15 minutes left. We're going to keep moving forward, trying to get to all the questions we can. Mark says, I have multiple net tumors in my liver, but they have not been able to locate the primary. So if this happens to somebody, Dr. Li, like, what advice do you give them? What's the next step? Like how, I know that's so important in this disease. How do we approach this?
Sure. That's a challenging and excellent question that Mark raised. So there are scenarios where we might not necessarily be able to find the primary based off of imaging. So this is really where potentially doing the pathology evaluation, it's really good to have a excellent pathologist that will do potentially initially special stains to see where the tumor might be arising, whether it's in the GI tract or the pancreas. Your pathologist sometimes can do certain types of stains that will lead you towards favoring a diagnosis of where the primary is coming from. Sometimes even doing that, you still don't know. And in those cases, potentially there could be a role in terms of kind of genomic profiling or genomic sequencing of the tumor. So there's different types of technologies that can take a piece of the tumor that you have been able to obtain in the liver and then essentially do testing on it to see if it has certain types of mutations. And if it has mutations, let's say that is more frequent in pancreatic neuroendocrine tumors, then you know that potentially this is a neuroendocrine tumor possibly arising from the pancreas or behaving like a pancreatic neuroendocrine tumor. If it has mutations that are more consistent with other sites and everything, then you get a clue in terms of the fact that it could be potentially coming from those other sites. There's also another test that kind of leverages on this called kind of cancer type ID that has been used for neuroendocrine tumors to, also potentially get a kind of a genomic diagnosis of potentially where the primary tumor is coming from. And you can certainly use that if everything else has not been able to tell you where the primary is coming from. Usually, if it's in the liver and it's truly an unknown primary, and if it's a low-grade neuroendocrine tumor, we oftentimes will classify it very similar in terms of how we classify our GI neuroendocrine tumors and presume that potentially this could be a neuroendocrine tumor in the small intestine. But really kind of do that pathologic workup. And then also if in certainly extreme cases, that there have been cases of, let's say, surgical exploration of the small bowel to see whether or not sometimes you can have these very tiny neuroendocrine tumors in the small bowel, and the only way you would be able to see them is to surgically explore that, even for someone that has disease that has spread to the liver. But that's a much more extreme scenario and everything, and that should really be discussed, with your providers if it's worthwhile to do that.
Yeah, absolutely. Another question from Wendy about carcinoid heart disease. What is the treatment for that? So let's take a moment, if you can, Dr. Li, and talk a little bit about that, since this is our first question about carcinoid heart disease, and establish like what that is, where, how it happens, and then, how do you approach that? How do you treat that?
Yeah, so excellent question again, Wendy. So for patients that have functional neuroendocrine tumors, where they have excess serotonin secretion, and as a result of that excess serotonin secretion, they can have something that's known as carcinoid syndrome, which oftentimes consists of flushing, diarrhea, and then ultimately damage to the right-sided heart valve as a result of that excess serotonin hormone in the bloodstream. So in some patients, if they have prolonged excess serotonin in the bloodstream, it can, as I mentioned, degrade the heart valves in the right side of the heart, and that can ultimately lead to carcinoid heart disease. And here, and when you develop carcinoid heart disease, you might have swelling in the extremities of your body, fluid in the belly, and become very uncomfortable, and sometimes also have certainly shortness of breath as a result of those. So the management for carcinoid heart disease is really, if the valves are really in fairly bad shape and you're already having symptoms, then it's potentially to do an operation to replace the valve, because then once the damage is done from the excess serotonin, you can't necessarily reverse that on the valve. So you might have to go with an aggressive surgical intervention to replace the valve to alleviate the symptoms immediately. If the valves are not yet in significant critical shape, then it's to really try to lower your serotonin levels as quickly as possible so that you potentially prevent further damage. So as I said before, there's numerous different ways to lower that serotonin. If you have disease in the liver, potentially embolization or surgical debulking might be the quickest way, because you're essentially just getting rid of the tumors as quickly as possible to decrease that serotonin production. If that's not possible, then somatostatin analogs can potentially, suppress the release of serotonin. And then now there are ongoing clinical trials exploring the role of telocrostat ethyl or Zermelo in terms of for patients that have carcinoid heart disease, in terms of what's the efficacy of that medication in terms of lowering the serotonin and potentially preventing negative outcomes for those patients with carcinoid heart disease.
Yeah. Awesome. Thank you. And thank you again, Wendy. Jane says, this is not a question for you, Dr. Li, but Jane just asked if you could say the names of the drugs a little more slowly. Jane, just so you know, we added those into the comments so that you can see those. I totally understand. That's one of those things where people that deal with that all the time, you're used to hearing that word, but sometimes those lengthy drug names can be a little hard to catch on to. So we put those in the comments. I just wanted to let you know. Next question, Dr. Li. And this one doesn't come up a lot, so I'm interested. I'm glad this came across. Terry says, the question is, what is your opinion on SBRT? And I don't get that question a lot about SBRT. So let's take a moment and establish what that is, how it differs from PRRT, and then what's your opinion on it, or when is it most effectively used?
Sure. Excellent question, Terry. So SBRT is essentially a stereotactic body radiotherapy. So this is focal external radiation that's delivered to the tumor. So very different compared to PRRT, which is infused through the vein and then travels throughout your bloodstream to get to the tumor. So SBRT, I completely agree that there are only kind of unique cases where we might consider SBRT for neuroendocrine tumors. So if someone, let's say, has a painful site of disease in the bone, and that bone lesion is now potentially compressing on the spine, and it's causing a lot of pain for the patient, that is one of the times where you can consider SBRT, because then that will deliver a high concentration of radiation directly to the tumor in the spine and hopefully cause immediate relief for the patients. And there's been patients that we've treated with this and everything, and they've done really well, where you deliver that focal dose of radiation to that area in the spine, and suddenly their back pain that they've been struggling with at the time of recurrence goes away immediately, and you preserve kind of the central nervous system in terms of the spinal cord, and really protect the cord in that scenario. There are other situations, like I said, for example, if you have disease growth in one area while you're on systemic therapy. So, for example, let's say just one area in the bone, or sometimes very rarely, let's say just one area at another site that you cannot get to with other different types of modalities of treatment, then to prolong the time that you are on the same systemic therapy and really try to, as we say in the field, try to turn this disease as much into a marathon as possible,
right,
you might want to spot treat that with SBRT. And then the final scenario where this occurs is for patients that sometimes very rarely develop brain metastasis from their neuroendocrine tumors. So if they develop brain metastasis, a lot of our systemic treatments that we have right now are not very good at crossing the blood-brain barrier, okay? So in those patients that have brain metastasis, oftentimes you will be able to deliver that focal-based dose of radiation to the brain metastasis and treat the brain metastasis and use your other therapies to control the disease outside of the brain.
Got it. Thank you, and thank you for that question, Terry. So Ed has a follow-up question on the carcinoid heart disease answer that you provided, and he just says, what type of damage is done to the valves? You mentioned that there was damage done to the valves. I think you wanted a little more elaboration.
So essentially, over time, what happens is that the valves start to degrade and wear down because of the excess, hormonal production from the serotonin. So when that happens, what happens to the valves is that they start to leak. They're not as strong, because normally what happens to your valves is that when your heart is pumping, they essentially, open up and close during filling as well as release of blood from the heart. So what happens is that when the blood is when the valves are damaged, they can't close properly. And as you can imagine, when your heart now pumps, without that closing of the valve, you essentially just get backflow of blood to other areas of your body, such as your extremities or your abdomen. So essentially that leaky valve is causing essentially backflow of blood, and that's why you will develop symptoms like swelling in other parts of the body.
Got it. Thank you for clarifying that. Dr. Li, what about the future? What about things in the near future that you're excited about, that you feel like will help us take some strides forward, help you do your job better? Is there anything that you've got your eyes on that you really think would help you do your job more effectively?
Yeah, as I mentioned, I think, neuroendocrine tumors, we're just at the cusp of, potentially making some big strides, I think, again, for neuroendocrine tumors. And I think there's several different areas that we can think about in terms of approaches that we're excited about. One is the role of what's known as additional oral target therapy agents. So traditionally, we've only had everolimus or Afinitor as an mTOR inhibitor, and only sunitinib for pancreatic neuroendocrine tumors. But we're on the cusp of all these additional potentially VEGF inhibitors, as well as inhibitors or something as a class of medications known as tyrosine kinase inhibitors that will have activity for neuroendocrine tumors and hopefully lead to FDA approvals, in clinical trials, either as a single agent or in combination moving forward. So there are several of these compounds that are being involved, including, surufatinib that has already demonstrated efficacy in the Chinese population, as well as the ongoing Alliance clinical trial with cabozantinib. So I really think that this is going to be kind of the next push for neuroendocrine tumors. Why do I think that? Is that, as I mentioned from the very beginning, you have to think about what the landscape has looked at for other diseases that are very similar potentially or have similarities to neuroendocrine tumors. So if you look at kidney cancer, these are agents that has had significant activity in kidney cancer. And when they've been combined with immunotherapy, they have revolutionized the care of kidney cancer. Kidney cancer is a very vascular tumor, just like neuroendocrine tumors. So you can see very similarities in terms of pathways that these drugs might target. And that has then translated from kidney cancer to, let's say, liver cancer, which is now going through an explosion of these agents, being FDA approved and having tremendous efficacy for a very aggressive disease. And again, liver cancer, we do a lot of the same things that we do for neuroendocrine tumors. We do embolization procedures because they're very vascular tumors. They share similar pathways that we can potentially target. So I really believe neuroendocrine tumors is going to be kind of that next tumor that's going to benefit from these, oral tyrosine kinase inhibitors, either by themselves or potentially in combination with things like immunotherapy and revolutionize that. So I think that's one component. I think the other component is, how do we potentially improve on PRRT? Yeah. So, there are potentially, alpha emitters that are being developed and everything. And I think that's also a very exciting prospect. So, but at the end of the day, I think you have to have all of these in your toolbox. It can't just be one. We can't just focus on one. So we have to really divide and focus on all of these, from target therapy to PRRT, and then potentially with immunotherapy combinations with target therapy to further improve immunotherapy, which we haven't done so far.
Yeah, absolutely. I'm glad to hear that you feel that way, and I feel like we're on the cusp of that too. And everybody that we've had on the show is kind of feeling the same way. So, looking forward to the future. Brian says, great show and informative discussion again. Thank you for this service, Brian. Thank you for being here. This is what we do it for. And I just wanted to mention this one, Dr. Li. Deborah says, thank you for this service. And thank you, Dr. Li. I have an answer now to a very troubling question. And she'll be meeting with Dr. Halperin next month for the first time, who we talked about at the beginning of the program. So that's it for our show today. But folks, I just want to say before you go, I love how long, like, everybody stays on the show and the numbers stay consistent the whole time. And live videos, especially long ones like this, typically start high and then just like peter off, and hours grows, and then everybody stays for the whole ride. And that tells me that we're doing a good job providing value consistently for the whole show. And that's like such, the best feedback for us to see. And it's because we have great guests like Dr. Li on the show. Dr. Li, thank you for your time. I appreciate you being here, my friend.
Sure. Thank you so much, Ray.
Absolutely. And thank you all at home, as always, for joining us. We hope this program helped answer some of your questions. Reiterate for a final time, if you have further questions, follow-up questions, or we didn't get to your question, go ahead and message CCF here on the Facebook page in a private message, or reach them at carcinoid.org. Thanks, as always, to our presenting sponsor, Tercera Therapeutics. We would not be able to do this program without them and their support. And finally, my name is Rain Bennett. I have been your host. Thank you for watching, and please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everybody.